can. So sorry about the interruption. Next slide. So before we jump into our presentation, did anybody have any questions about the infant testing? And again, I just put the link into the chat to the most recent recommendations so that you can review kind of more details as well and see the full figures that we went over today. Okay. So if you do think of any questions, don't hesitate to reach out. I am sure that we will be talking about it more as we go into some of our case presentations and presentation today as well. So with that, I am going to see Dr. Gupta. Were you able to join?
Yes, I'm here. Thank you.
Perfect.
Yeah.
Perfect. I was so nervous you weren't able to. I was like, oh no, because I saw your email pop through right at the beginning. So wonderful. So we have with us today Dr. Neil Gupta, and we're really excited to have you being able to talk about kind of more of hepatitis C and pregnancy as well. So I'll pass it off to you to get us started.
Thank you so much, Emmy. It's really nice to meet you and to everybody on the line. If I could request co-host, sorry, I jumped on a little bit late, so I think that's probably why it got left off, just so I can share my screen. And while you're doing that, oh, okay, great. Thank you. And while I'm getting these slides up, so let's put that. I hope everybody can see my screen in full view. So it's such a pleasure to be with you all here. I've had the pleasure to join other ECHO sessions in other states through this virtual world, and it's always been a really rich discussion. So really pleased to be with you all today. My name is Neil Gupta. I'm coming from the Coalition for Global Hepatitis Elimination at the Task Force for Global Health. I'm an internist and pediatrician by training, and I've worked primarily in public health, in global public health over the past 15 years, primarily in sub-Saharan Africa and South Asia. There I had the opportunity to actually see hepatitis B and hepatitis C prevention and care and treatment and the lack thereof in many low resource settings. And very recently, in the past couple of years, had the opportunity to join the Coalition for Global Hepatitis Elimination, which, if I can just mention in by way of background, is a 501(c) organization based in Decatur, outside Atlanta in Georgia. The Task Force for Global Health really hits on disease elimination programming across a wide range of diseases, polio, neglected tropical diseases, et cetera. But over the past couple of years, had the opportunity to establish with Dr. John Ward, who came from the US CDC and led the Division of Viral Hepatitis there, established the Coalition for Global Hepatitis Elimination just approximately 4 years ago. So it's a young organization, but the only one that's really dedicated to hepatitis elimination, viral hepatitis elimination around the world. So one of our projects over the past several years has been thinking more about hepatitis C in pregnant people and those that are diagnosed antenatally, and thinking more in depth about how we can improve coverage of linkage to care and treatment for this critical population. So I'm going to go through a few slides just of background on this situation, though I'm sure all of you clinicians on the line have seen this in much closer detail even than I have. But from a public health perspective, wanted to just emphasize why this issue is of such public health importance if we were to achieve viral hepatitis elimination in our generation, and what we at the Coalition are doing along these lines, and to hopefully recruit you to contribute to the efforts that we've undertaken here. So just broadly speaking, there's over 14 million HCV infections worldwide amongst individuals of reproductive age and childbearing women. We can see that this is widely distributed around the world and is an issue with over 20% of global hepatitis C infections now amongst this age group. We also know, and this is no surprise to any of you on the line, I'm sure, that hepatitis C is increasing rapidly in the US in several key populations. But amongst pregnant individuals, we've seen a over threefold rise from 2009 to 2019 in terms of the hepatitis C rate diagnosed antenatally. And this rate is higher in in Alaskan Native and American Indian populations, in white populations, as you can see to the top right here with a demographic breakdown. Those without a 4-year degree in the bottom left here on the C graph, and then quite dramatically in rural and rural adjacent populations as compared to urban populations across the US, shown here in the bottom right graph. And just to drive that point home, I think, as you all know on the line, Tennessee and Greater Appalachia is particularly affected by the hepatitis C epidemic. And that goes for infections diagnosed in pregnant individuals as well. The dark blue here being a higher rate of hepatitis C infection in pregnant individuals, down to lighter blue and gray being where there's fewer infections or no data. Amongst the 10 counties with the highest hepatitis C rate in pregnancy, 8 of those were in Appalachian states. 1 of those was in Tennessee. 4 of those were in Kentucky, actually, and then 1 in North Carolina, 1 in Virginia, and 1 in West Virginia, respectively. Oh, and this data, might I add, it was published in 2021 in JAMA based on infant birth records across the country, so quite representative. We know that as testing has been now become universal amongst all pregnant individuals, or recommended universally, I should say, the rate of testing has increased and has more than doubled since 2011. And you can see this inflection point in 2020 when the new guidelines were released from the CDC and USPSTF to test all individuals during pregnancy. So reaching and approximating around 40% of individuals with hepatitis C testing completed. So getting into where we see quite a challenge is now that there's more people during pregnancy with hepatitis C infection, and more of those being diagnosed given recent recommendations, what to do when an individual is diagnosed with hepatitis C antenatally. And I think this is where I'd love to hear from all of you and your experience and what happens in real time. All the data and in speaking with providers around the country is that very few individuals who are diagnosed antenatally actually make it into care and treatment. This was a review of Medicare records across 8 states for women with opioid use disorder in pregnancy. And it found that within 6 months of delivery, less than 6% of individuals who who carried an HCV diagnosis in pregnancy actually had a visit or any medication prescribed for hepatitis C treatment within the 6 months after pregnancy. So it does beg the question, and this is a question that we've been pondering, and you might have questions around this too, is if direct-acting antivirals and hepatitis C treatments that we know are safe and effective in non-pregnant populations can be eventually used, or could be the standard of care for pregnant individuals in the 3rd trimester. And so this has started to percolate through the guidance committees. So the AASLD-IDSA guidance on this topic is that despite the lack of evidence in this area, there can be a consideration of treatment during pregnancy based on patient-physician discussion and risk-benefit analysis at the individual level. So they're not saying you can't do it. They're just saying they don't recommend it quite yet across all populations. And this was an area that really needs more data. So what is the data out there currently? Pregnancy, in terms of safety categories, only sofosbuvir and ledipasvir do carry a safety category for pregnancy, and that's category B, which is deemed to be safe in pregnancy. There have been two PK studies conducted now prospectively, one of soft litiposphere and the other of soft hepatosphere, which just released at CROI earlier this year, which showed a high level of safety and no transmissions amongst women who were treated in the third trimester, though those studies were quite small and really focused on the pharmacokinetics of these drugs in pregnant individuals and lactating mothers. There have been several prospective case series that have been put out. The N on those total is 26, probably in more like in the 30s to 40 now. If you look across the globe in terms of case reports of who's been treated in the third trimester with outcome data. And if you look at the federal adverse event reporting for pregnancy while on direct-acting antiviral treatment, the data is very incomplete. There have been a lot of cases of exposure reported, but not outcomes tracked. Surprisingly, out of the 137 exposure registries on the FDA website, there's not a single registry, or there wasn't a single registry for hepatitis C or exposures to any hepatitis C treatment in pregnancy. So with that gap, we have been collaborating with the US CDC to establish a case registry for individuals who are exposed to hepatitis C treatment during pregnancy. That could be one large group are those that start treatment and then become pregnant while on treatment, go back to their providers and say, do we stop? Do we continue? Should I see a specialist? And then there's another big group, which are individuals, providers around the country who are treating in the third trimester. And I'd say that's not standard of care. That's not frequently reported. But there are quite a few providers around the country who are taking this upon themselves, doing that individual risk-benefit analysis and determining that treatment is beneficial for a group of their patients. So in order to capture that information and to capture that real world learning, we launched a registry. It's publicly available here. You can use this QR code or link. And it walks you through a very simple REDCap-based data entry form, which collects very basic information, anonymized, regarding the patient's case and their exposure history. So what treatment was used, what were the dates of that, so we can calculate at what point the fetus was actually exposed to the medication. And then, if available, maternal and infant outcomes. So the primary outcomes of interest listed at the bottom of the screen here are the pregnancy and birth outcomes, particularly congenital defects, if identified in the infant. And then secondary outcomes being whether FC treatment was continued, and if so, if the mother achieved SVR, and the infant's hepatitis C status, and whether DA exposure during pregnancy actually is reducing the rate of vertical transmission. We at the coalition release a biannual policy update with the information that we have collected. So we're now into our second round of, we're actually into our third round of data collection. Our second policy brief was published just last month. It's available on our website with the link here. Hope you can download that. Overall, we have 30 registered cases. These are both cases that have been published in previous case series, as well as cases that are occurring around the country and around the world. So you can see we have several cases from other countries around North America, and are engaging countries in Africa, Asia, Europe, providers in many geographies to actually submit data for the registry as well. Out of those two groups that I was mentioning, we have 5 cases that have been submitted for exposures during the first trimester. We're finding it more difficult to track outcomes on those individuals, but we do have outcomes available on 2 of those cases. And then this larger group of mostly published information, but several additional cases of treatment that was conducted in the third trimester, or I say after the first trimester, among which we have infant outcomes in 20 cases, and none have reported congenital anomalies to this point. You can also see information on preterm birth as well as complications around delivery. So I wanted to wrap here to leave a little bit of time for questions or discussion, but just wanted to leave you with these key takeaways. One that I think is very clear to all of us is that hepatitis C is an epidemic. It's increasingly diagnosed in pregnancy, given universal testing recommendations. That there's a big question mark around what you do after you diagnose hepatitis C, and this has caused providers a lot of stress and anxiety around the country, I think, in really waiting for linkage to care and treatment after pregnancy and the breastfeeding period is over for appropriate treatment of the mother. And as we noted, in the last presentation, testing for infants, which is super critical, and hopefully the new CDC guidelines can help move the needle into improved infant testing. Treatment during pregnancy may be an option currently based on the IDSA guidelines, but we do need more data before that becomes widely used in standard of care. And the TIP-HEP-C registry that I was talking about earlier that we're conducting from the coalition should provide valuable data, very transparent, open, can be used for Medicare and Medicaid claims, for treatment coverage, and will really accompany clinical trials that are becoming more and more frequent in this space. So there are current trials with both soft hepatosphere as well as GP in pregnancy, and hopefully that larger scale perspective data with a sample size of projected somewhere between 50 and 100 for each of those two drugs will give us the more information around this, but capturing real world exposure and data as it comes out will help individuals diagnosed today and not years from now. So I'm going to stop there. I'll stop sharing my screen, and I'm happy to turn it back over. And I'd love to hear any experiences that you as providers have had in this space as well. Thank you very much.
Thank you, Dr. Gupta. I think it's so interesting and really encouraging to hear that we're hopefully going to be to a point that hepatitis C treatment during pregnancy, could be more of a reality and more common. So really interesting to hear that. But before we move on, as he said, I would really like to take an opportunity to invite others to ask questions or add comments. Dr. Chastain?
Yeah, I'm going to cut in line. Dr. Gupta, thanks so much for sharing. I'm a hepatitis C treatment provider at Vanderbilt in Nashville, Tennessee. And one of the things that is really challenging about looking at this type of real world outcome data is that we care about both the person who is receiving the treatment as well as the infant. And as a adult provider, I might treat a person and they may incidentally become pregnant. And we may make a decision together about whether to continue treatment or discontinue treatment. That type of information often can be registered, but I think one of the real challenges I have is actually being able to reflect authentically on the status of the infant, about what is their health truly, what type of follow-up have they had, what type of markers. And I think that's what's the power in some of the clinical studies, is that those studies have been able to follow the pregnant person as well as the infant subsequently. And I think the real world challenges is that actually the care for those two is often separated. There are certain registries and or health departments and or programs that sometimes have connected, for lack of a better term, mother-baby registries or health outcomes that certain states or certain programs have. Are there any type of opportunities for the TIP registry to partner with any of those groups to be able to kind of assimilate data that might be able to monitor for medications that were administered and the health of the pregnant person as well as the health of the infant, because those type of data cohorts or systems would seemingly overcome some of those real world registry challenges.
Absolutely, Dr. Chastain. I think it's an incredible point, and prospectively, it's going to be very difficult to follow long-term outcomes as well. You know, amongst children, which need to be really incorporated into the equation and calculation for decisions that you're making in real time. We have worked with several partners. One of the examples that we're following is the pediatric HIV registry that really has moved the needle in terms of pediatric or mother-to-child transmission, though that was a formal indication for prevention of mother-to-child transmission, where here, we're really looking at linkage to care and improving coverage amongst individuals who are diagnosed during pregnancy. So we are looking into, one, how to make this registry more robust in terms of follow-up for those that are identified as treatment exposures. Very hard to identify those, but once you have them, how can we follow them over time? And secondly, how to work with pediatric providers, often knowing that patients or children or cases that they've identified are HCV exposed, but very, very rarely are they actually DAA exposed. And so that's the challenge that we've been facing, working with researchers or even the CDC registries that have looked into this before. And they're just now actually starting to incorporate treatment exposure into those infant birth records as well. So it's something that's rare. I think it's still a rare case that we're finding, but point very well noted. And I think there are challenges with these real world registries for sure. But thank you.
Thank you.
Thanks, Lindsay.
Hey, so I just wanted to ask, are there any known identified barriers that are preventing women from seeking care postpartum?
Absolutely. And I think they're the ones that you would expect, right? So I think during qualitative interviewing, it's really around the intensity of the transition of care, postpartum. So transport, visits, multiple visits, fragmented care, insurance restrictions, when your tail of Medicaid, Medicare coverage is actually going to expire after, the postpartum period. Child care becomes a big issue. So I think these are the structural barriers that you would imagine that not only limit the infant diagnosis part, the infant testing part. I think it's some of the same challenges that then really challenge maternal linkage to care. Oftentimes, active substance abuse as well is quite the challenge. But I think they're the ones that you would typically expect. And I don't think it's hepatitis C treatment per se. I think it's more engagement, in the medical system than anything.
Thank you. I know I think we have talked about it maybe in previous sessions, but I know that one of the things we really strive to in our perinatal hepatitis C program within our department is trying to identify those individuals that have been perinatally exposed to hepatitis C and getting them linked to treatment, both birthing parent and infant, but really thinking about it as to whether or not they've been exposed to DAAs during that process is really an interesting piece. And I would honestly have to look back at the data and see how much we're really asking that information, because our goal is really just to get them, let's get you tested, let's get you into treatment. So really like being able to talk about this. Any other comments or questions?
I mean, if I can just add one more comment here, to your point, I think the DAA exposure aside from the registry, how can we prospectively improve linkage to care? I think it speaks to Lindsay's question earlier, is a few suggestions have been floated amongst both in the literature as well as the providers that we've been talking about co-located care. How do you co-locate, hepatitis C treatment services with, OST services or with postpartum care really being at the forefront? How do you improve the time to diagnostic confirmation? How do you task shift training and provision of hepatitis C treatment, to their providers, even, pharmacists, trained pharmacists, specialty pharmacists in many geographies. I think ECHO is going a long way for this, but, can we think of more strategies to actually improve that linkage to care process? So we'd love to, if you have any suggestions, if anyone has any experiences with that or interventions that they've used in their own clinical practices, we'd love to hear that. And please do, drop me a line.
Yeah, absolutely. That's an excellent point. I can always be strengthened, I think. So that's a great point. Thank you for mentioning. Any other comments or questions before we move into our case presentation? All right. Well, if anyone thinks